Good evening, everyone. Welcome to this evening's Adult and Health Services Overview and Scrutiny Committee on the 31st of July 2025. It's now 7 p.m. and I would like to start this meeting. I would like to remind everyone present that this meeting is being live streamed and recorded for publication on the Council's website. There are no planned fire alarms this evening. In the case of an emergency, please evacuate the building using the nearest available exit and congregate at the assembly point outside the college. Item 1, apologies for absence. Apologies received are from Sharon Stoltz, Robert Percy, Councillor Maldoni, Cherry West and Kim James. Robert Percy is being represented tonight by Kerry Armstrong. Are there any further apologies? No, that's it, thank you. Okay. So thank you to everyone for coming this evening. This is the first meeting of the newly formed Adults and Health Overview and Scrutiny Committee. I'm Councillor Elizabeth Rigby. My intention is for us to look at a wide range of social care and health issues, taking into account all the many changes that are afoot. A special focus on reducing health inequalities, which feeds into all aspects of health. So item 2 is the minutes. Since the annual council in May 2025, as I've recently alluded to, the People Overview and Scrutiny Committee was split into two committees, Adult and Health Services and Children's Services. The last People Overview and Scrutiny Committee held referenced Adults and Children's Services. I move that the minutes of the previous meeting held on the People Overview and Scrutiny Committee on the 4th of March 2025, as outlined in the agenda, are approved as correct. Are there any comments on the accuracy of the minutes? Okay, thank you. The minutes are approved. Item 3, declarations of interest. Does anyone have any declarations of interest to make? Okay, thank you. Unplanned scrutiny items and members' rights of reference. I don't believe there are any tonight. Thank you. Right. Item 5 is the Mid and South Essex NHS Foundation Trust 10-year strategy, which is on pages 15 to 18 of the agenda. May I ask Kevin Garrod and Donna Chung to present, please?
Thank you, Chair. I believe we have a set of slides. Yeah, thank you so much. I'm just going to run across 4 or 5 slides by way of bridging between the extensive document that we produced and the paper that supported that. So I hope for councillors that's okay. So if we could, sorry, it's okay, we don't need to move on yet. I think the important introductory comments here are about this being a 10-year strategy. We've taken a considerable amount of time to develop the strategy, some 15 months of listening, consulting, listening, and reconfirming some of what, or most of what we were hearing. There are immediate actions that, as a trust, we need to begin to progress in line with the ICS and others' expectations around the midterm plan. So that is the point about it being a 10-year plan. This is not exactly a work in progress, but it's certainly a long-term plan for the future. But it's also being constructed against the backdrop of an NHS long-term health plan for the future, the considerable restraint on all of our spending as public servants and public services, and the background of change now around a local government review. So I'm just sort of setting some of the context for where that strategy is beginning to lean into. So if I could have the next slide. We made a decision as a trust to maintain our existing values and our existing mission statement about one team working together, being excellent and compassionate and respectful. Post our merger in 2020, we'd put a considerable amount of effort into ensuring that we began to build a suitable culture for the future. And our board felt that a change of direction precisely in those sort of terms at this moment would be probably unhelpful. What we do have is 4 new strategic pillars. So our people, our communities, our services and our partnerships, all of which have associated statements that go with them and about the long-term trajectory in the I, we, our partners type of statements within that context. So I thought I would just dip in to give you a flavour of what some of our consultation actually told us in that space, and without revealing any secrets, in terms of our people, I'm sure councillors may be aware that our staff survey results for the acid test of friends and families and would you recommend Mid-South Essex Foundation Trust as a place to work, was not great this year and was certainly not an improvement on the previous year. That indicates that there is a considerable amount of work to do and the board are absolutely prioritising that in a people and culture approach, which is moving towards its latter stages of development prior to implementation. But actually in the longer term plan, we've also got to support our people to become more nimble, more adaptable and more skillful and be able to carry the load that we are anticipating that they will require to do so in the next 10 years. And that is linked to our patients. They're older in general, they're often more complex, and there are often more complex solutions that are available to us and will become available to us. So I always encourage people to think about where we were 10 years ago, and perhaps live streaming and regular Teams meeting, if we think about technology, was just becoming a regular item. And now we're in a very different position. So if we move ourselves forward in a 10-year cycle, what technology will bring us then is still open to our shaping. Our services, in particular our tertiary services, so that's the Cardiothoracic Centre at Basildon and Thurrock Hospital, that's our cancer support from Southend Hospital, and our burns and plastics from Chelmsford, i.e. Broomfield Hospital. We would very much like to be able to expand and develop that and extend some of the practice that they are able to deliver as a tertiary centre into the mainstream part of our hospital activity. Capital and capital investment, some of the condition of our buildings requires further investment, so that case will continue to be made. But we have our CDCs beginning to come on stream. Thurrock, I'm given to understand, will open in the early part of the autumn, followed swiftly by the other three. And from a Basildon and Thurrock perspective, of course, the latter but the biggest at Pitsea will also help to carry some of the load around diagnostics and access for Basildon and Thurrock patients in the longer term. In terms of our communities, we heard a lot about the lived experience. We did an extensive consultation piece through our voluntary and community sector partners, through patient groups, about their experience of us as a foundation trust and 3 hospitals. And I put the 3 hospitals there because some of the messaging and merger takes time to really embed was about the differentials between Chelmsford, Southend and Basildon, and potentially an inconsistency in services and pathways being available in a consistent manner to our patients. So that's something that we will be seeking to address in the very earliest stages of the plan. We heard about communication, letter writing, how people are communicated with from our consultants, from our medical secretaries, and we heard about transport. So we almost left no stone unturned in that search for the real understanding of how people felt about us as a trust. And finally, but just as importantly, our partnership. So we heard about fragmentation, about cohesion, and about needing clarity in terms of the roles and aspirations of some of our partnerships moving forward. So you can, I hope, begin to understand how we secured the priorities and the actions that follow therein. Next slide, please. So I'm not going to delve too deeply into this one because this is sort of quite wordy, if you like, but I'm going to focus on one of our key ambitions about what our partners would say about us moving forward 10 years hence. And this sense of our people having the skills to be able to make that left shift that are fit for the future policy statements and a general direction of travel are indicating. So that's about shifting care and support for our patients closer to home and further away from our hospitals. But we need to skill our workforce, both from a culture perspective and their abilities to be able to do that. The sense about patient involvement, co-production, experience and co-delivery being central to our communities theme. The sense about how we are communicating with our patients and across our 3 hospitals and with our system partners. So our ultimate ambition in the partnership zone here is that moving forward, people will see us as the partner of first choice, and that we can trace our contribution to health inequalities and health outcomes for all of our patients and most of our residents in the area. So I think I'll probably dip on a couple of slides here just to take us to standardise and modernise, and then perhaps I can invite Donna for some closing comments and or take further questions. So if I could have the slide after the road for implementation. So there's some key bits here in terms of getting the basics right, including standardise and modernise over the first 2 years of our plan. There are elements of our merger agreement that we are still working on to bring to full fruition. There are the opportunities that we will see from the left shift. As an example, we have seen guidance in the last 10 days about the expected role of our clinical diagnostic centres in the neighbourhood health offer. So that is code for left shift and their role as anchors in that particular endeavour. We have clinical model options that are being worked up and a focus on consistent pathways and working with our partners such as the ICS to redesign services such as MSK and pain, where we have hospital, community and primary all collaborating in that pathway effectively and efficiently. To close this section down, our other major part of what we're doing, which we are expecting will help with our communications with patients, with residents, but also within the hospital, is our NOVA, our EPR, with EPA and others. And to give you an example of that, we have some clinicians who are completing their casework by needing to use up to 3 or 4 systems. So it's both time consuming to have to log into a different, I'm sure we've all had in a very flippant way, that same sort of experience when we're doing our banking or our credit cards or looking at our mobile device accounts, but this is real time, this is real lives, this is about being efficient as a trust. So I will park it there if people are comfortable with that. Donna, can I ask you to make some additions to that if you so wish?
I think, Kevin, you summarised beautifully. I think one thing to add is that whilst some of the wordings might look very hospital focused when we talk about pathway designs, when we have our clinical strategy group meeting within the trust, we always encourage this service clinical leads to think about how they work with the system partners, such as the system leaders in the stewardship groups that are already established, and if there is an established stewardship group, also make links to that, because there is quite a bit of that where partnership is very much the key, and we really want our partnership to deliver benefits for the local population, as like everywhere else in England, this part of England is also getting a little bit older, and the need is going to change, and hence that is really the underpinning part of our hospital's 10-year strategy.
Thank you both very much for the report. Particularly keen to see bringing healthcare closer to the community and to home, and nice to see all the engagement and work that you've done. What I'll do is I'll open it up for questions and then come back. So if we got any questions, Councillor Spate, please.
This is a 10-year plan for the Trust, and clearly we're here to look after Thurrock's best interests. Now, I'm pretty certain that if you went out with a clipboard and spoke to 100 people in Thurrock, more than 50% of those people would mention Orsett Hospital. Certainly more than 50% would mention Orsett Hospital in one way, shape or form. I've gone through the 2 documents that you've got in front of us this evening, and this is a 10-year plan for what you're going to do, and you mention Orsett Hospital once in a paragraph. You mention St Andrews in Billericay and talk about that. You mention other services and whatever. So, you know, the Foundation of Health cannot be unaware of the fact that a great many local services will continue to be provided through, I get the diagnostic centres are going to be coming on board, but you know, in terms of the actual clinical care, in terms of servicing, in terms of, you know, direct care with physicians, nurses, experts, consultants, all those people, are still going to be happening at Orsett Hospital for a number of years to come. Certainly a significant part of this 10-year plan. But you make no mention of what you're going to do about a hospital that everyone accepts is not fit for purpose, which desperately needs more than £10 million spending on it just to even scratch the surface of how bad it actually is. You know, you've got all those flowery words, all those lovely presentations, all those graphics using words like left shift opportunities. And I don't think that the majority of people in Thurrock really care or even know what a left shift opportunity is. I find it really disappointing that you've spent all this time, all this money, allegedly done all this consultation. And yes, there are some very nice promises in there, but promises, you know, are not what we need. What we actually want to see, the people of Thurrock, is an improved health service on our doorstep. And we're just not getting it. And what we've got is going downhill, and yet it merits one mention in one paragraph at the beginning of all this prose. So what are your plans for the next 10 years for Orsett Hospital?
I suspect you're aware of what I'm about to say. Orsett Hospital remains open and functioning. The precise plans around it at this stage, we don't know. And that's, or I certainly don't know. I can take it back and try and get a better response from you. But yeah, it's a particularly difficult time in terms of securing capital investment for much of our estate. It probably won't have escaped your notice that there was an item recently in the trade press, less, about the continuing, not necessarily dispute, but the backwards and forwards with the Department for Health and Social Care about money that was promised to the trust some years ago before the pandemic. So I think please appreciate that we are trying our best, but working against probably a very, very difficult background.
Sorry, second question.
Are you aware of the amount of work that has been done through this committee over not just last year or the year before, over several years, and particularly the significant amount of work that's been carried out by my councillor colleague Mark Hooper over there, who has made a particular effort to work to get Orsett upgraded and yet are you not embarrassed that you can sit here and say, I don't know? I haven't got an answer. Because I really just feel, you know, it's just shocking. Orsett Hospital has been a major topic for this borough. And you're just being completely dismissive of it. You're being dismissive of the people of Thurrock and the things that they care about. And yeah, you know, it maybe strikes a chord that St Andrews in prosperous Billericay gets a nice chunk of interest, but Thurrock doesn't. I just hope that you are embarrassed, and I hope you admit it. And it would be interesting to see what Councillor Hooper says if he has anything to say on it as well.
Chair. So I'll give a personal undertaking to come back to you with a written response around that, Councillor Spade. I appreciate your feelings and I appreciate your commitment to Thurrock. I've certainly been, not necessarily close to, but involved in the borough in one form or another in terms of connections with officers here for 20 years. So at personal level, I am at least familiar. I feel embarrassed, I must say, about the building at Orsett when I do visit it. It is not good by anybody's stretch of the imagination, and it doesn't give our residents or your residents and our patients a sense of being valued and supported. That much I'm absolutely quite willing to accept and would absolutely understand your comments. as always, these things often come down to money, and that's not an excuse, but it is what it is. But I can take that back. We have a new Chief Estates and Infrastructure Officer who is due to come into post in January. That feels a long way away, but I'm sure that we can come up with a written response to you about where we are precisely with ORSET alongside our colleagues in the ICS, if that at least provides a little bit of reassurance to your commentary. Thank you.
Thank you. Councillor Hooper, did you want to say anything at this time?
Yeah, all I'm aware of is that there's no real plans for the future of Orsett Hospital. They're not willing to change anything. And it is slightly disappointing we've not got a better definition of what that future will be within the 10-year plan. However, I do welcome the plan in a number of ways, because I think one of the things that's been really, really missing from my point of view is the partnership working, which you referred to. I know myself and other councillors have offered the hand of partnership, knowing that the trust is struggling, and that hand has not been taken. And I'd really be keen to hear more about how you're looking to proceed that in terms of partnership working. I would like to come back to the Orsett Hospital issue, but maybe I'll do that separately and report back to the committee at a later date. And I know you're right to Councillor Spate. I'll be grateful for a copy of that when you do so. As I say, keen to work in partnership, and I think that's been sadly missing, particularly in the last 2 years. So that hand of friendship is there to help you in very difficult circumstances. The Trust do deliver some very good services, like the cardiac service, which you referred to. I think that's some of the best in the world. But there are a number of areas where there are concerns, things like A&E, how we're going to actually deal with the growing population of Thurrock with or the region, I should say, because the region will grow population-wise considerably. What plans are there to take pressure off the A&E, particularly with the kind of preventative approach and the other options that people could use other than going to A&E, which is really designed for about 250 people a day, and it's probably senior 400 or 500 people a day.
Councillor, thank you for your comments. Do you need an immediate response from me or that?
Or some sort of response,
Yeah,
but I mean,
yeah,
I don't need to, but I mean, I'm keen to help the Trust deliver better care services for Thurrock, and to look at how the Trust can actually provide better local services to Thurrock, as in the 10-year plan, which I think is what Councillor Spate's alluding to, is the 10-year plan is looking at services that are closer to the community. We do have a great resource there. What's the future of that resource? But also that kind of partnership working, how do you see that going forward?
Yeah, so in the sense of the partnership working, there'll be no surprises that there has been some informal surveying behind the scenes, and we are just working out exactly how we respond to work that we've had from consultants that begins to pick apart what we need to do around partnerships, particularly with our GPs and the supply of sort of GP provision, and how we work into the neighbourhood health. So the guidance that we have currently is about the expectation of how an acute trust will begin to redeploy its services, whether they are AI-led, whether they're virtual or people-led, away from its hospitals. So we are shrinking our 16,000 people that work for Mid-South Essex. To give you an example of what that could or what that might look like, I already alluded to the MSK pain, pathway development and service development. But for instance, in Southend, our audiology is a hub and spoke model, so people only come into the hospital when they're absolutely required for specialist care. The audiology and the piece that goes with that is delivered from primary care networks, from surgery. So we will be looking, and we are very grateful for that offer of the extended hand of partnership and support around how we redeploy some of, or as much support as we sensibly can do towards community settings. You know, just parking at our hospitals, just travel to our hospitals can be a challenge, whichever one of the 3 hospitals you go to, and we wish to avoid that being a difficult experience alongside the anxieties of receiving care. So, yeah. Thank you.
Thank you. Yes, so I'll just follow on a little bit from what Councillor Spate and Councillor Hooper have been alluding to. I mean, the plan is for these community centres to ultimately take over what is currently offered at Orset. The main issue is how we sort of transition that into it. Talking about transport, bringing things closer, and I know that you've mentioned about bus services, but at the moment it is still difficult for people in some parts of the borough to get to the Long Lane site. So do you have timing plans in place for when the diagnostic centre will be open? What sort of time lag will there be until the sort of better transport links for people?
So our scheduling on the Thurrock CDC opening is into the autumn. Teams are just being recruited for those that needed to be recruited that weren't, if you like, already in our workforce, but we're always going to be cited to work to Thurrock. In terms of the transport, I can't comment on that. I can get some clarity from our CDC programme director. But we have a range of things that we're beginning to look at in the community transport space with colleagues from the ICS, in particular to the southern part of Essex, if you like, so Thurrock and Basildon, from some tests around an Uber option, so Uber Health. Apparently they have a health division, are very interested in working with one of our innovations, Deep Medical. So trying to use that technology to make life easier for people to be able to travel to their appointments. And we are aware of some of the challenges that are currently there with community transport, particularly where they are reliant on volunteers that may not be available. But we will, I suspect, be looking towards technological solutions. They may not be, it's an Uber, it arrives now. It might be a collective car, if you like, that does that. But these are in early stage discussions. And with ICS colleagues, we are working to spread that out from a Basildon base.
Thank you. Councillor Fish.
Thanks, Chair. I'm obviously concentrating on Thurrock as well. But my issue is more about staffing. Thurrock has a historical issue about being under-doctored, and you're talking about moving services out of the hospital into the community, which sounds to me as if it's going to put more pressure on those doctors. So what are your, and over the years, I've been involved with the Health and Wellbeing Board, for instance, and we've tried to crack it there. We've looked at primary care strategies, this kind of thing, but it doesn't really seem to be improving significantly. So what's the strategy for the next 10 years to make that happen?
So I'm going to defer that. I would suggest, Tom, if you're able to either take that now or in your session, because that falls to our colleagues at the ICS. Although your point is absolutely valid, the sorts of things from a hospital perspective we will be looking to do is to help our consultants to support GPs more. So very often, you know, I can talk better from the mental health perspective. That's some of my professional background. But having consultants with the ability to provide additional support to those GPs who are generalists, who don't necessarily have that specialist knowledge, is the anticipation of Fit for the Future for our strategy plans as well. So that greater integration with GP practices, whilst it might not immediately solve the understaffing issue or the undercapacity issue for doctors in this part of South Essex in Thurrock, at least the access to expert professional support about particular conditions and particular specialisms should at least both reduce pressure on them, both in terms of time and the professional pressure of how they feel about having to deal with people arriving with a whole range of complex conditions.
Yeah, I think the other thing is to say, to a certain extent, the staff will follow the work as well. So I think the intention isn't for the work to just be lifted out of hospital and kind of dumped into general practice, but rather the intention being we want to get hospital clinicians out into the community supporting patients more locally. And so I think that's going to be an important element of the change in the way that we deliver services within the NHS over the coming years. And so that's something that we are working through at the moment in terms of how we facilitate that. Alongside that, obviously, and I know the last time I was here, we were talking about the work we're doing to strengthen core general practice capacity in terms of staff, both in terms of GPs through things like the fellowship program and the training practices that we've now got operating in Thurrock, and also the wider professional set that we now have. So we have a significant number of kind of advanced nurses, paramedics, therapists, pharmacists working within general practice. So we're eating into it, but we've still got a long way to go. So we're going to need to continue to push on with that. And I'm very grateful for the support of colleagues within the council and more generally within Thurrock in terms of exploring the options. And so a few weeks ago, Jen Craft, the MP for Thurrock, ran a session with general practice across Thurrock. I was there as well as with other colleagues with the ICB. Councillor Hooper was there to really start to look at what more can we do to encourage GPs to come and work in Thurrock and stay in Thurrock. A big element of that, of course, is general practice estate, and how can we make sure that we've got enough clinical space. And we are progressing, with the schemes that we've got in Purfleet at the moment. We are progressing a scheme in Tilbury in partnership with council colleagues, and we're going to continue to push on in terms of the use of the available Section 106 money where we've got that, but equally also look at how can we develop a more strategic relationship with developers, so we can make sure that that general practice capacity is built alongside any new development, rather than the sort of the delay that we've currently got. And we've got examples from elsewhere in Mid and South Essex. So if you take Chelmsford, for instance, where we've managed to do that successfully, and we want to try and do the same thing here in Thurrock, because I think one of the key things GPs have told me is that actually we can recruit into Thurrock. GPs want to work in Thurrock. We just need to make sure there's the physical space for them to be able to practice and see patients. And so that's the job that we've got to kind of continue to knuckle down on and to address.
Thank you. We've got Councillor Benson, please.
Thank you, Chair. Just following on what the other councillors have said, the west of the borough, particularly Purfleet and Ockenden, it's an awful long way to get to Basildon. And when they get consultation come through, they can pick Durham, which is nearer sometimes, but the transport's poor. They can't get there as much as they can Basildon. And I just think the west of the borough seems to be very underrepresented, get a lot of problems with GP appointments, struggling like mad. And they end up going to A&E. It's a terrible thing, putting big pressure on A&E ambulance service, and it really does need sorting. Thank you.
So I can come back on that. So yes, so I think as part of the wider picture is how do we address all parts of Thurrock to make sure that we're addressing the specific issues in each area, and how can we, alongside with the publication of the 10-year plan for health, how can we look at potentially trying to make sure Thurrock is at the front of the queue for some of the new initiatives and proposals that are coming down around kind of the creation of neighbourhood health centres, around the new roles which are set out within the plan in order to increase local capacity, so to better support local residents than we're currently able to do.
Thank you. And we are hoping, I think, in February to get a more detailed report on the NHS 10-year plan with a special focus perhaps on A&E. So we'll hopefully look more into that then as well. Thank you. So we have Councillor Manoir, please.
Thank you, Chair. My question is to do with the reference to like a joint up approach and partnerships in the borough. And I'll share something quite personal that recently I had a bereavement of a family friend of mine. She lived in Tilbury and she was terminally ill with cancer. And she was in the hospital for quite some time and she came out. And I don't want to get into specifics because at the end of the day, there's some details that I don't know. But long story short, she was at home alone. There wasn't really seemingly any support or aftercare from when she left the hospital. And she ended up dying alone, and people didn't even know she was dead until a few days later. And for me, considering she was somebody who spent her whole life working in Grays in palliative care, helping other people, the manner in which she died was obviously very tragic. And I can appreciate that you can't answer for individual people and circumstances, but my question is, we're looking at a 10-year plan, but right now it seems as though services don't seem particularly joined up. And I'm specifically talking about terminally ill people, people with cancer, things where, okay, we can appreciate that they're coming to the end of their life, but that dignity obviously should be expected throughout their entire, lifetime. So my question is just, what can we do now to try and improve that sort of cohesion within the services, whether you're in hospital, out of hospital, moving things to the community? Because I hope that nobody else in Thurrock will have to experience what she had to go through. And my second point is, I appreciate you guys all coming and giving that presentation, because at the end of the day, it is important to have a long-term strategy and plan. And I think some of the kind of anger or disgruntlement from some of the councillors, it's understandable. I don't think it's necessarily at your feet. You're coming here and putting yourself out there and letting us ask you the questions. So I just want to say I do appreciate that, because sometimes I think that anger can be a bit misplaced. But in terms of my initial question, what can we do right now to make sure that our services, our health services, especially in Thurrock, are truly joined up? Thank you very much.
I'm just going to say a couple of comments, which I hope will talk to your the unfortunate circumstances that you as a family or friends experience, and then invite Donna perhaps to say something in terms of some of the clinical care and some of the change there. Alongside that neighbourhood health, and you will hear that, you will hear the health secretary talking about neighbourhood health. We have integrated neighbourhood teams which are developing, and we've already seen some considerable improvement, particularly, for instance, around homelessness, and for those people who are on the edge of homelessness, for instance, in Thurrock. So one of the other changes around the changes to ICSs is the movement of, I won't say power, that's not the right word, but the movement of responsibility to place-based working with more evidence on the provider side of it, which in Code 4E put provide our community providers and the hospital, amongst others, alongside our GP. So the space has been created to begin to make that happen. The first focus is very much on frailty, because frailty, of course, has an impact not only on the individual. Those people are much more likely to come into hospital and much more likely not necessarily to return to hospital from there to their place of residence. So I want to say watch this space, but we have strong guidance. There are lots of people, and the Alliance is, of course, working in that space. We really need to do that better, and the hospital needs to do that better. We have the guidance and we have the clarity now from the plan about where we need to focus and what we need to do, from supporting people around economic activity to supporting people with frailty. So that full strata from health inequality through to end of life to palliative care is very much a considerable point of juncture between acute services coming out and being redeployed into community provision to produce, we hope, better outcomes for our people. So yeah, Donna, do you want to say something particularly in relevance to cancer, maybe? Thank you.
I think very much we know the quality of end-of-life care isn't equal. One of the good things actually about Mental Health is that cancer has a very strong patient co-design group. In fact, they've actually designed the co-designed ways of working, and we have included the whole of it as it was that they designed into our 10-year strategy in the full document there. I appreciate this is a public meeting, but if it's possible, I'll be really keen, because I know that our end-of-life clinical leads will be probably interested in understanding the story and learn from it, and that's very much is how that side of the service is working. And not only do we have an active co-design group for cancer, actually we have one of the representatives of our cancer champions working in our clinical board as well for cancer. So if it's possible, I'll be really keen to understand a bit more outside of this meeting.
Thank you. And Kerry, you wanted to come in.
Yeah, I was just going to add around the partnership working, just to say that I think in Thurrock that partners have been working very, very closely for a number of years now around looking at how we can transform system-based and place-based working. So we've had we've been developing integrated locality teams in 4 areas based around our primary care networks for a number of years, and we started prior to actual kind of national guidance on that. So actually national guidance is following the direction of travel that we were already in, and we're already seeing some real benefits of doing that in terms of joined up working and making sure that the priorities of those areas reflect kind of what communities want. I mean, there's more to do, obviously, but actually that's already in train, and we're already seeing real benefits from doing that. So I think it's very high on our agenda, and we're just about to refresh our integrated care strategy in Thurrock, and we probably need to make sure that we have absolute join up with the work that's being done here and any work that's been done that's going to affect Thurrock communities. So it is done as one system rather than actually in separate kind of bits.
Thank you. And Councillor Hooper.
I just wanted to raise a number of points, if I may, Chair. Just in terms, you mentioned funding for the buildings and repairs, which is from the previous government's funding as part of the joining of the trust. I did speak to Jane Craft about that when I became aware of it, and she's raised it with the Minister. So I'm hoping you'll get some more positive news about that in the near future. In terms of, and this is my frustration around partnership working, we know about the diagnostic centre. No buses on a Sunday, but your service is open from 7 till 7. So I've been trying to work with your transport team and our local council to actually try and put a package together so there's actually better transport to that site. Now, I think the council may have been able to find some money to provide us a Sunday service for buses, but I did, after about 7 months, get a meeting. We promised a meeting 5 weeks later. It hasn't happened, and that was 3 months ago. Can you understand my frustration about partnership working? So I'm hoping to get some news about that fairly shortly. Can I just also raise, and I thank Councillor Manoir, and recently Councillor Fox raised issues around discharge from Southend Hospital to Thurrock. There seems to be a gap here, and maybe we could have a meeting to look at this, because there are a number of concerns around discharge from Southend back to Thurrock. And I would value if we could actually do some to look at this issue, because I say that this is about the 5th case I've heard in about 6 months. Right, I'll leave it there, but I will just say, Councillor Fish, in terms of the GPs, as Tom was saying, that we are looking to work with developers on 106 money, and as Tom said, meeting with the GPs, it was kind of, if we build it, they will come. Okay, and I would like to thank Tom and the ICB, because in January we were bottom of the league in terms of head of population, but we've actually brought in, I think, 17 to 20 training GPs to Thurrock, which has raised our position. Now, it's better than it was, and there's work to do, but I'm just saying that we are moving in the right direction.
Thank you, Councillor Hooper. I will undertake to take that message back into Southend, and our IDT and our managing director there. I'm part of the Southend Operational Management Group, so I can take that message in and try to get a candid and careful response calibrated for you as to what might be going on there. And if you would be so good enough to furnish me with the name that you were given, not necessarily here publicly in this meeting, but I will also progress that for you so that we are able to try to make some progress in that space. Because, yeah, having the facility there and no way of servicing it for those people who might need it is not the way forward. Thank you.
Thank you. And I think Kim James is doing a discharge report at the next meeting, so that might link in nicely with what you've raised there, Councillor Hooper. Councillor Johnson.
Thank you, Chair. I too welcome the move to the 10-year strategy for over the 3-year goal stance. And whilst your report has 4 headings that are your points of reference, or 4 clear priorities, I think you call them, I think you'll agree that as an umbrella, they're massive, each and every one of them. I mean, you've heard that from the questions coming in here, and that's just from Thurrock. So I'm just a little concerned where we turn over and say that you're only going to be reporting back to Ball twice annually. If we're looking at a 10-year strategy here, do you not think that that should be a little bit more frequent? Because I would imagine once you report to Ball, then we would see more of that report.
Thank you. We've got Councillor Chuckwu, please.
Oh, thanks, Chair. I'm just thinking, what can you do now, just for my residents, because some of them are still struggling to make an appointment with GPs, right? And some of them don't actually know how to use the technology available to book an appointment online. Is there anything you can do to help? Because it's all about getting closer to community, taking this to community. Is there anything you can do for now? Thank you.
I'll take the question about GP. So yes, there is. So we are working alongside all of our GPs in Mid and South Essex to support those who can use digital tools in order to be able to use those tools. But the purpose of that being to then free up the capacity, so then the people who can't use the digital tools or who want to make a phone call or something like that can get through. And so try and move away from the 8 a.m. rush process that there currently is at the moment, in terms of people all calling up at 8 a.m. and then getting very frustrated, understandably, sitting in a queue to get an answer. So that rollout's ongoing over the course of the next few months. That should hopefully help free up some capacity in terms of the phone lines for patients who need to call through. The other thing that we are also actively promoting and will continue to promote is also the alternatives to seeing a GP in primary care. So we now have Pharmacy First, which is available across the patch. For a number of minor ailments, actually people can go to their pharmacy and get their medication and treatment there and get assessed. And so that's not being utilised as well as it could. Although our pharmacies are very keen, obviously, to support that, and so we've got some more work that we are doing at the moment in terms of both helping signpost people to those that support, both kind of they can do that proactively, but equally also when someone calls through to the GP to help then also free up capacity alongside the longer term work as we've described in terms of increasing the number of training GPs, which we know where people generally train, they want to stay, and so that gives us hope in the longer term. But the immediate term, there's definitely more we can do to signpost people to alternatives and make sure that we free up capacity on the phones by those people who can use digital, using digital, but not requiring everybody, obviously, to do that if that's not appropriate for them.
Thank you. So we are sort of running quite close to time now, so if we can just keep the remainder of the questions quite brief, if possible, please. We've got Councillor Chuckwu next, please. You've just asked. Councillor Spate, please.
Thank you, Chair, for your indulgence. I think, in a way, that this meeting is sort of symptomatic of the confusion that there is about health, and that we're here discussing this section of the meeting about the NHS Foundation Trust, and to help and assist, Tom steps in from the ICB. So, Joe Blogg's watching this on camera, who's doing what and who's responsible for what, which absolutely exemplifies the thing about partnership working. And I'll just touch on 2 points with a question. yes, I also was aware of the GP meeting that Jen Craft facilitated. I found it really interesting that they brought along the Thurrock Residential Development Partnership, which is basically an organisation that is amalgamation of house builders, and they do need to be engaged. I found it interesting that some of those people at that meeting were the ones who pledged to build a health centre in Linford as part of the housing development that the NH says that it doesn't want and it can't afford to staff it. The same project managers are promising a care home in their current North Corringham application, so they're mixing health in, but it's a little bit of smoke and mirrors, and I'd just like to know if people are really happy about that. And another issue that comes up on, Tom mentioned estates management. In our side of the borough, we had a surgery that's shutting down on Southend Road. John will know about it. And it's now moving to share premises, which are not really suitable, a couple of miles away, causing problems for its people who are on its register. Ideally, it could have relocated to the Corringham IMC, but apocryphally, we're told that it's full and there's no space available and they couldn't go in there. And yet a section of the premises are being utilised by Thurrock Council Children's Services, people who work in there just a couple of days a week or work at home, and for love nor money would never come and work in this premise because, you know, we're premises that's got acres of space and dozens of empty desks, but they won't come here. And we could have freed up that space for direct first contact with people. So there just seems to be a lack of joined up thinking and a lack, you know, we're working in silos. TBC's in one silo, ICB's in one silo, the trust is in one silo. You know, you've got a 10-year plan. Tom's going to talk about his 10-year plan. Are we really making progress?
I'll come back on that. There was a number of questions in there, Councillor Spade. Are we making progress? Yes. But is there still lots to do? Yes. The work we're going to talk about kind of dovetails into the work specifically that Kevin's described to you today in terms of, and kind of effectively the work within the hospital's 10-year plan forms part of the wider NHS work that we'll talk about. In terms of join up, it hasn't been good enough in recent years. And we're committed to improving that. And so we are trying to do some quite practical things. So me and Councillor Hooper now have agreed to meet monthly, and so we can make sure we drive forward on priority projects and we can start the dialogue going. Equally, I think the conversation that we had that Jen facilitated a few weeks ago provides an opportunity for us to reset the way that we work alongside developers. So we're in a position very early doors to say this is what we believe is needed in terms of local health infrastructure. What's the balance in terms of the developer contribution versus NHS contribution or other sources of contribution, and get that designed in from day one and get the agreements in place from day one, rather than sort of I think what we've been very guilty of, I think my observation would be within the health service and in the ICB, is that we've reacted at, you know, far too late in terms of, so we're too late to the party. If we do get some money, it's done on a very formulaic basis, as opposed to saying, well, actually, what does the local community need? And so you potentially, say with Section 106 money, you end up with very small pots of money that you can't really do anything significant with. And we've got to completely turn that on its head. And that's the conversation we're now having. So I think it's good that we're making some progress in some areas, but we've got a long way to go. And it's a very legitimate criticism.
I'm just keen to add to that the story of reform, if you can count it, that across the last 20 or 40 years is to very slow incremental steps, if at all. Having said that, the outline that we have from Fit for the Future does at least afford us a greater level of clarity over the different roles. And Councillor Spence, I absolutely take and accept your commentary about how blurred the lines are between the different parts of our services, and actually that can lead to confusion and dissatisfaction from many, many quarters, residents, councillors, patients, the press. So I want to be negative about the past, but optimistic about the future, I think, from what we can see. And it's easy for me to say that because in 5 years' time, I will hopefully be retired and I'll have a Sir Steve Redgrave moment, and if I'm still here for the next round of reform, can people please remind me, and I will leave the room forthwith. Thank you.
Councillor Leakey, please.
Thank you, Chair. Mine is a very brief question, which I know because you spend lots of time talking about your service. I remember last ONS we talked about having some graduates to be attached to the GPs so that they can increase the capacity. That was what part of the plan. So I don't know how that's going. Is this a part of the plan, or what's the progress at this point?
So it's progressing. So yes, so it's something we've committed to. We are progressing with the initiative. It's probably still too early days to get kind of some good metrics out, but I'm hoping, in the coming months, we'll start to be able to demonstrate whether it's making the difference we hoped that it would. But no, we're ploughing on.
Thank you very much, and thank you to everyone for all your questions and contributions. I think obviously there's some good plans afoot. Do we know when we will sort of get the first sort of review or anything on progress, please?
I'm expecting that we'll have further development in the autumn, because actually the task that's set internally within the hospital is for individual hospitals, divisions, departments to dovetail in their strategy work and their plans. And we're being really quite forceful in what we call enabling strategies, and that they really do begin to bring this together and make life of it, because we can set the high level direction, but of course, as usual, the devil is in the detail, and actually the how, and if you like, that's the next stage that will come forward. And I'm sure that we can make sure that we disseminate that information, if not attend again, as relevantly asked, whether it's a health and wellbeing board, this group, or other forums that would need our support.
Thank you very much. Thank you. So we'll now move to item 6. I don't know if you'd like to stay or for this item. Yeah. Okay. Thank you. Yeah. So item 6, which is the NHS Mid and South Essex Integrated Care Board update. May I ask either Tom Abel or Claire Hankey to present the report, please?
Yes, of course. And thank you for receiving the report. And so the purpose of this update is to update the committee on 4 items which are set out on the next slide. So firstly, an update around the decision that's been made on the consultation that's been held around community services, particularly which affects St Peter's Hospital in Malden. Secondly, Claire will do an update around our medium-term plan. Thirdly, an update about a change and transition to long COVID services in Mid and South Essex. And finally, an update around some of the changes that are happening to integrated care boards across England and what that means for us here locally. So if we can move on to the next slide. So there was obviously significant consultation around the future of a number of community services, as I say, principally affecting services in Malden. And following that consultation process, we came to a set of decisions earlier on this month. So the first of those is around changes to community stroke and intermediate care beds. So we have consulted on the closure of the stroke rehabilitation beds which were provided at St Peter's Hospital in Malden, and we presented 2 potential future options in terms of the provision of those beds and the balance between those community stroke beds and what we call intermediate care beds, and those are generally discharge for people who need some further rehabilitation post-discharge from hospital. The first of those options was the centralisation of all of those specialist stroke rehabilitation beds at Brentwood Community Hospital. The second was to split those community stroke beds between Brentwood Community Hospital and Cumberledge Intermediate Care Centre that is in Rochford. And that would mean that we would retain some intermediate care capacity on the Brentwood Community Hospital site. And the decision was made that we would pursue option B. I think it's important to say it does not affect the existing intermediate care provision that is at Mayfield ward in Thurrock Community Hospital, and that will be maintained and continue. Secondly, there are some proposed changes around what were freestanding midwifery-led birthing services at St Peter's Hospital in Malden, and the decision was made to permanently relocate those services to the birthing centre in Braintree, but to retain the 14,000 antenatal and postnatal outpatient appointments in Malden. And then finally, in terms of the outpatient and diagnostic services that are provided in St Peter's Hospital, it was agreed that they will remain at the St Peter's Hospital site whilst work is undertaken to look at the future of the provision of services on that site. In terms of what that means for Thurrock, which is set out on the next slide, so actually there's fairly limited impact in terms of the impact for Thurrock residents. So most Thurrock residents will continue to receive care in the same way that they do now. As I say, intermediate care will continue to be provided at Thurrock Community Hospital, and those patients who require stroke rehabilitation will continue to receive that at Brentwood and or Rochford, which is the case as of today. And equally, we will continue to support existing home-based services here in Thurrock. Two of the things which I think might be important to note that came through the consultation and we've committed to as an ICB is firstly around birthing services, is to more actively promote the availability of the home birthing services that we have available across Mid and South Essex. So hospital colleagues have done a lot of work and have successfully recruited fully to all the midwifery roles and vacancies across the hospitals. That means that we can now stand up, a full home birthing service for low-risk women if they choose to give birth at home, and so that's something that we've committed to and will continue to focus on. The second area is the work that we are doing in partnership with Thurrock Council and others around what we call the home first approach. And so what can we do in terms of improving the availability of physiotherapy and other support to be able to support earlier discharge from hospital where that's appropriate, and for people to get the support at home when they need it. And we're seeing some good success with that, and particularly in Thurrock, we also have the fantastic engagement and relationship with By Your Side, which is a scheme which is operated by Thurrock CVS to provide lower level, more kind of social support to people coming out of hospital. So people need some help getting the shopping in, people need a key safe installing, things like that. And so some of, I think, the learning that we've received through this consultation will point to things that we can do to strengthen local services further. So those decisions have been made. In terms of the next steps mainly focus around the implementation of those changes around Malden, and we'll be working in terms of looking at the future arrangements for the St Peter's site in Malden. Secondly, if we move on to the medium-term plan, I'm going to hand over to Claire, who's just going to talk through the work that we're doing around the plan for health services in Mid and South Essex more generally.
Thanks, Tom. Thank you, everybody. So the medium-term plan, you'll be pleased to know, is actually an aggregate of all of the work that we've been talking about this evening, and actually is the opportunity to bring it together under one kind of shared plan across NHS partners and local authority colleagues as well. The key challenges that we face in Mid and South Essex won't be any surprise, and actually we've referenced quite a lot of them tonight already in the conversation. So services do feel stretched, and we do know that there are long waiting times for services. We know that people have difficulty accessing care when it's needed. We know our workforce is overstretched and tired. We have poor technology in areas, poor systems and poor facilities, as we've talked about this evening. And we know that there's rising demand as people live longer. And not only are they living longer, but they're living with a number and a range of conditions which make it more complex, and they have more complex care requirements. We know the public purse is tight, and budgets are constrained across the public sector, but we also know the cost of living, the spiralling costs in putting things together. And all too often we're diagnosing illness too late, so people are kind of suffering more because we're not able to tackle it through early prevention. So the medium-term plan is for us a kind of a 5-year roadmap that pulls together the underpinning strategies from various other organisations and brings it together to make sure that we're responding locally to the asks set out in the National 10-Year Plan. So you'll have seen, hopefully, in that 10-year plan, there's a real focus on 3 key shifts that the government talks about, and that's prevention over treatment, so making sure that people are helped to stay well and manage their conditions early. There's community over hospital, so making sure that we're making that shift from hospital-based care to care closer to home or even in the home, as Tom's described. And then obviously that digital transformation, making sure that we're using technology to its maximum capabilities and capacity to make sure that there's, you know, good efficiency in the system there, but also recognising that there is an impact on patient experience. For those that can use digital means, it's great. For those that can't, it means that there's additional capacity for them in other ways. So some of the key areas of transformation, if you could just flick to the next slide for me. Thanks, Carly. As I've said, it's a 5-year roadmap, so actually if we can go on to the next slide. So our improvement program's kind of under these broad headings, really, and you will have picked up some of this evening, actually, in some of the stuff we're talking about. So that first proactive preventative care really does look at how we make that shift from hospital-based services into community and into people's homes and making it much more easy for people to access care closer to where they live. Urgent and emergency care picks up that perennial problem around people accessing urgent and emergency care because they don't understand or aren't able to access a different pathway to receive immediate treatment. So work's going on in that space to look at what else we need to do to provide different options for people. Community mental health and learning disability and autism recognises the kind of joint role we have across health and social care and local authority partners in terms of doing more and meeting that rising tide that we know that's been, you know, there since the pandemic and the increased needs around mental health access and support. Support services efficiency is around making sure that we're not duplicating efforts around some of those enabler functions we have, whether it's digital kind of support functions such as HR and things like that, and making sure that we're making the best use of those across the public sector, making the best use for the public sector pound. Acute services sustainability absolutely plays into the conversation that we've had tonight with Kevin and that 10-year strategy for the hospital and how the hospital is going to kind of improve and transform over the next 10 years, and that kind of picks that up under there. And then obviously the last one is that strengthening primary care, because actually if we don't strengthen primary care, then we can't make the shift from hospital to community happen. So it really is an opportunity to kind of bring all of that together with oversight and those kind of high level ambitions across the whole system, but making sure that those particular pieces of work are going on to deliver the kind of strategic move that we want to make and to meet our kind of responsibilities under that national 10-year plan. It also helps us set the foundation for what Tom's going to talk about shortly in terms of that transition for integrated care boards and the new role that we'll be playing going forward.
Thank you, Claire. And if we just move on to, yes, so in terms of long COVID, so as committee members may be aware, during the pandemic, the NHS across the country stood up a number of long COVID services when it was a kind of a very kind of misunderstood or not understood set of syndromes which were being experienced. What we've seen is a significant change in the demand for those services with a kind of 6% reduction in referrals over the course of the last year, and also a change in terms of the recovery rates of people who are displaying long COVID symptoms, with most recovering within 4 to 9 months. And so having undertaken a review of the service and the fact that actually what's proving to work is actually making sure that we get people into the right specialist service depending on their presenting conditions, so be that a respiratory clinic, be that chronic fatigue services or something similar. The intention is to integrate the long COVID service into mainstream care by the end of this year. That follows kind of the pattern that's being seen across the country, and what we will do is we will look to make sure that any existing patients will continue to receive support, but as I say, what we'll look to do is to facilitate direct access to the right specialist resource depending on the presenting condition of the patient if they are potentially experiencing long COVID symptoms. So that will include the respiratory services that we've got within the system, both in the hospital and within the community team services that we have, and equally also our mental health services, therapy services, and our paediatric pathways for children. So that is a change that we're working on, and we'll be talking directly to the patients who are affected as a result of this change to make sure that they are appropriately supported as we go through the transitional period. And then finally, I just wanted to give a quick update to the committee around some of the changes which are happening to ICBs. So as committee members may be aware, the government announced a 50% reduction in running costs for ICBs early on this year. So work has been underway since then to look at the NHS's response to that. As a result of that, decision has been made to move from the current 6 ICBs that we've got across the east of England to 3 ICBs. And so here locally, that will mean the creation of a Greater Essex ICB that will bring together what is currently Mid and South Essex Integrated Care Board alongside West Essex, which currently sits with Hertfordshire, and North East Essex, which currently sits with Suffolk. That is, so we are now kind of committed to that process, and that's as part of a wider set of changes to ICBs. So the total number of ICBs in England is anticipated to move from 42 to 26 ICBs across the country. So in terms of the work that we're doing to prepare for that change, which we currently are aiming to be introduced from the beginning of April. We have completed the chair or designate chair and chief executive appointments to those new ICBs. Those recommendations from those interview processes have gone through to government for approval, and so we will let the committee know once that has been confirmed. We've also started consultation with the executive teams of all 6 ICBs. That consultation will conclude at the beginning of August, with appointment processes running through kind of late August into early September. And as I say, the aim is to then move into wider staff consultation, although the timescales around that are to be confirmed at this moment in time. As part of this transition, there's also going to be a change in role of ICBs, really to try and help better clarify who's responsible for doing what, as Councillor Spate said earlier today. So what we will see is a move towards providers having kind of greater independence, I guess, and a move away from the ICBs having kind of regulatory oversight of local providers in each local area, with those responsibilities moving to NHS England, and with the ICB moving to what's being called a strategic commissioning organisation, which will work in partnership with partners, including local authorities and others, to address some of the issues that are being seen locally. My best way of describing this is that for people who were around in the time of primary care trusts, it is something somewhat similar to that sort of model, if people can recall that. So we there's nothing genuinely new in the NHS, is there? But that's the general move, and the work that we're going to need to do locally is work through how do we respond to the ambition set out within the 10-year plan for health published by the government around the creation of neighbourhoods and the creation of kind of local neighbourhood delivery organisations. And so there's a lot of engagement and work we want to do with council colleagues, with GPs, with our providers to work through how do we make that successful. So we don't lose some of the good things that have happened whilst ICBs have been doing what they've currently been doing, but equally make sure that we preserve and protect some of the fantastic, joint local working that's been going on in all of our places over the course of the last few years. So still more work to do on that, but that's very much our commitment in terms of making sure that we commit to that. In terms of kind of conclusion, next steps, so clearly the ICB is going through a significant change programme, but we are committed to making sure that we continue to do our jobs whilst we go through this change, and we continue to be committed to the programmes of work that we've got in place across Mid and South Essex. We clearly would like to make sure that we are coming here regularly to update you in terms of how these changes are playing out and what that might mean, and equally we're obviously alongside that going to work very closely with all of our stakeholders and partners across Essex to make sure that they're very much involved in both the ICB change programme and our programmes of work more generally. I'll leave it there and I'm happy to take any questions.
Thank you very much both for your presentation and updates on what's happening. So again, a good move towards prevention, early diagnosis and bringing care closer to home. And also interested to know more about the neighbourhood working approach as well. I'll open it up to questions initially, I think. Who have we got? Councillor Spate.
I think you've got a man who's got the reputation of Mr. Fix-It after the trust and the ambulance service, and I wouldn't want what you've got in front of you at the moment. In terms of, and you've got the ever-moving feast of instructions coming out of Westminster, which clearly can't help you, because you may decide on a policy decision one day and the next day you're getting a message saying something's going to change. You've got a huge amount of work, and I was quite impressed by what you've laid out so far. But overriding all that must be the sort of directive that you've got to cut running costs by, I think it's 50% by the year end, or the current financial year end, which just seems an enormous task. Is it really attainable? What baffles me is, what I'm worried about is you've got good work starting, and good work takes time. It isn't done overnight, and it needs to bed in and it needs to work. Do you fear that there's, I fear, and I'm wondering whether you share that fear, that pressure will be ramped up as we move towards the year end, where the financial targets are not being met and you're getting more and more and more pressure on your shoulders that may then lead to speedier decisions that are not as well thought out and whatever. I mean, I suppose I'm really asking you to comment on government policy, which isn't fair, so I won't. But, I mean, is there anything that you think that we as councillors can do in terms of helping you get where you need to be? Because I think that, I mean, it's easy for us to come in and throw nasty questions at you, and I like to think we can learn a little, and are there things that we can do as councillors, lobby our cabinet, lobby our MPs and things like that to try and help it? Because I just think you've just got such, I would say it was virtually an impossible job, but you know, good luck with you in attaining it. But there is so much change and there is so much pressure. You just, you read the health press and directives that are coming out all the time. As I say, I don't know how you sleep at night.
Not well, some nights anyway. And then other times I'm exhausted, so I sleep very well. But no, so it is high risk, and so we need to be really careful around making sure that we don't do anything silly, because you're quite right. There's a risk in the pressure and the pace that you make a rush decision and that's the wrong decision. And equally, we don't want to lose momentum that we're trying to build in terms of the change programme that Claire was talking about. In terms of, I think there's a couple of things I think partners can do. So we've got a very productive conversation going on with all council colleagues, including Thurrock, around what is it we can practically do to preserve capacity and capability to deliver that change and deliver in partnership. And I'm incredibly grateful to colleagues from Thurrock Council and equally Southend and Essex in terms of how they're engaging with us on that, in terms of particularly around the place-based work, because I think that's going to be absolutely essential if we're going to make the changes that we need to see, because the services need to be delivered to people. People live in communities, and we need to work in communities if we're going to deliver the right services that meet people's needs. So that's one area of work. I think the second area of work is making sure you're keeping us on our toes a bit, in terms of, I think it's important to make sure you're calling out where you think that there's gaps or issues, and so we can be alert to that. One of the things that I'm personally concerned about is, as part of this change, there is a set of changes to a number of the statutory responsibilities of ICBs being proposed in areas like safeguarding, continuing healthcare and things like that. Although that's understandable, that is not something we should rush, in terms of it's too serious to individuals and to public safety in some instances for us to rush in some of those places. And so, and I'm being very clear in terms of with NHS England and others about how far and how fast we think we can go. I suspect that we probably won't get it all done by the end of this year for all those reasons. I think the other reason is clearly a change of this size is going to involve significant level of redundancies. If you'd be given that most of the running cost of an ICB is staff cost. It's not. We don't have a huge non-pay cost. So you know, if the priority for the NHS is to make sure we deliver on our financial plans for this year, you know, we're not going to be able to incur potentially the level of redundancy costs to fully deliver that 50% reduction. And so I think there's a high likelihood it's not going to be by the end of this calendar year, and indeed it may well slip into next financial year. We just need to work that through. But I think, you know, keep us on our toes, raise the issues and concerns as you see them, because yeah, we need as many eyes as we can get on this change programme, the better.
Yeah, I think one of the things, and I'm going to try and, later in our meeting, we've got a work programme issue, and I want to try and get something on it. I'm very concerned, and it's nothing to do with you as far as I can see, it's an NHS directive going immediately. We're probably, there's a real risk we're going to lose Thurrock Health Watch, for example, which has caused a great deal of pain and a great deal of anguish to the people who work there. And I find it really interesting that we've got an item on our next meeting about discharge, which is a piece of excellent work that's been done by Thurrock Health Watch, which I think will help you guys and whatever. So I'm hoping that this, you know, it took about scrutiny. We need to be looking at, there is a pathway, I think, we can fund it through Thurrock Council and through some monies that are going to be available to us, and we would do that. But, you know, I mean, one would hope that, you know, you would recognise that good work by a council trying to do something constructive, and keep that service alive, because that is my ultimate fear, that we'll lose that grassroots connectivity because of a budget sheet where somebody said, oh, well, we can get rid of that because it's not that important. Well, it's massively important. So, you know, I mean, just so you know, some of us are aware of that, and we're fighting to keep it, and hopefully we might get a bit of support from you as well.
No, certainly, and I've reached out to Kim and the chief execs of both Southend and Essex Health Watch to understand what it is we can do to support them and to work alongside them, because I think you're entirely right. The grassroots insight is what we need in terms of, because that's what tells, you know, they tell us what matters to people, and that's what we should be worried about in terms of the delivery of service. And so we need to make sure that we do whatever we can to support them and support that really important work.
Thank you. Are there any further questions, comments? Anyone there? Oh. Got away quite lightly, didn't you? Yeah. Thank you very much. Yes, so you've obviously got a lot on your plate, managing the reductions and all your plans as well. So yes, so do keep us updated. I'm always concerned when it's moving to sort of digitalisation and use of apps and virtual wards, for what happens to those that can't use those, and that could exacerbate any inequalities. So what happens in those instances, please?
Yeah, we are acutely aware of that as well. So actually some of the work that we've been doing, and actually working with in Thurrock as well, we've managed to secure a bit of funding to work on a kind of digital exclusion programme. So understanding what are the barriers sometimes to people being able to access digital care. And we've been working with a number of local community and CVS groups, particularly from ethnic minority backgrounds, people supporting older people and advocates like that, to understand much more what it is we need to do to make those digital applications work for them, or what are the barriers to them being able to secure access digitally. And we're working in a number of different places actually to kind of coalesce all of that information to then see how we can take that forward to support. And actually it's something that our local authority colleagues are working with us on, because we're aware that those same people will be trying to access council services in the same way through digital means as well. So it's not unique to health, but it's actually something we can all do as the public sector organisations in terms of supporting people to become more digitally enabled, but also then opening up that capacity for those that really can't or aren't able or aren't willing to access things through a digital format. So it's good on the one hand, you know, it is, you know, progress and stuff, and lots of people now do, you know, banking online and stuff. So actually making their healthcare accessible in that same way that they used to is really, really positive. But yeah, it's really important as well that we don't forget and lose those people that aren't able to do that.
Yeah, I think the other thing I'd add is that we need, so I think the thing I'm very conscious of is we need to not do the sort of Model T Ford kind of thing in terms of you can have whatever you want, but you have to, you have to do it in this particular way. In terms of, I think it is absolutely fine and appropriate for us to make sure there's different channels to access care, which are most appropriate for you. I feel very happy that I can order my repeat prescription on the NHS app, and I don't have to call up the GP and bother the GP to do it. Indeed, I'd love it if I'd be able to, when I have to go and get my blood test, I don't have to go and pick up a form at the GP practice to then carry it to the blood test centre. But that's something we're working on at the moment. But clearly, other people will benefit from popping into the GP practice because they don't feel comfortable using the NHS app or for whatever reason. And I think that's okay. I think we just need to, but I think we give people the choice in terms of having the access that works for them. And that's what we've got to design into the service. I think one of the things we fall into too much within the NHS is saying there's one way of doing it, which then excludes people. And we need to say it's okay to have more than one way to do it. It's the means to the end, but it's the most appropriate thing. And as I was saying earlier, actually, if people do want to use digital tools, that then creates capacity for those people who can't use them to be able to get better, easier access to things that they're currently struggling to get access to.
Oh, thank you. That's great. Thank you. The only other thing I was thinking about was the home care. So people being able to be treated at home. And again, this could impact adversely on, lower socio-economic groups where we're trying to improve the health inequalities, because if their standards at home don't allow for that, what happens then? Do you help them make up that standard, or do they have to stay in hospital? What sort of happens in that scenario?
So I think that's a work in progress. So one of the things we have implemented, we implemented just before kind of Christmas this year, is something called the Integrated Care Transfer Hub. And so what that is effectively a multidisciplinary team. So it's got colleagues from the hospital, colleagues from our community services. It involves colleagues from social care and also the voluntary sector, so the by your side work. Really to try and help support and coordinate discharge from people who are ready to leave the hospital, but they're going to need something in addition before they go home or at home when they get there. And that's both been very successful in terms of reducing delayed discharges. So we now have the lowest level of delayed discharge in the country here in Mid and South Essex. But equally, it's enabling us to identify need earlier, and because you've got all the right people together, they can take action to try and support individuals. So if there's a housing issue, if there's an adaptation issue, if there's an equipment issue, that can be resolved kind of more proactively than it was previously, just by people talking together. And so I think we've made some good progress on that. I think the next step, and this is a little bit further away, but it's linked into the neighbourhood health model of the future, is, and actually also links to my point around access, is we need within the NHS in terms of identifying those people who are most at risk and most at need, and working through what is the specific set of interventions and support we provide to those people in concert with housing, in concert with other partners, to meet that need, and so they don't end up in crisis. Because again, I think the way that we currently deliver the service, again, is quite one size fits all. So you can get a package of care, but it is this many sessions or this many 10-minute appointments where the community nurse will pop in and see you. We've got to kind of turn that on its head and say, actually, there is a cohort, particularly in our most disadvantaged communities, which actually require legitimately more support and more so they can live happier, better lives. And we know that by doing that, that's a good thing for the health service, because it will reduce the instances of the 999 being called or presentations at A&E and things like that. But we require a completely different way in the way that we work and the mindset. We work much more similar, I think, to the way that social care colleagues work. So that's sort of very much our ambition. We've got a lot of work to do to get our head around how do we do it and how do we make that switch. But I think that's definitely got to be part of our future if we're to have an NHS that is sustainable for the long term and meets needs for the longer term.
Thank you. That sounds promising. Thank you. So, are there anything further? Or no? Okay. Well, thank you both very much for your report. And I don't know if the four of you would like to stay or if you're very welcome to leave. Thank you very much. Bye bye. Okay. So we will now move to item 7, which is the Thurrock supported housing strategy on pages 32 to 126. And may I ask Kerry to present the report, please?
Thank you, Chair. Just to introduce the strategy, I think in terms of supported accommodation, some of you have been here for a while, may remember that we had a Supporting People programme from 2003, which was a government-funded programme for supported accommodation. Now, that ended in 2012, and since then, supported accommodation has really developed in a bit of a piecemeal way. So the purpose of the review and then the strategy that's come from that review was really to pull together a cohesive approach or a cohesive model for supported accommodation. And the strategy outlines 10 objectives that we think are important to deliver that new vision. But obviously I think Tom's kind of articulated quite well, obviously do that on a way that's bespoke to individuals. So it's not a one-size-fits-all, but it's a model that's flexible and able to flex around people's requirements and variability. So just a bit of background. Supported accommodation, in a sense, is for people who have a need where they can't live in their own accommodation. They need some form of support, and that's backed up by often by care. Sometimes it's personal care, sometimes it isn't, depends on the individual. And we provide that for adults of 18 to 65, and those people are kind of split into different cohorts, for want of a better term. So learning disabilities, mental health, autism, neurodiversity. We spend in Thurrock over £8 million per annum, so it's quite a big spend of commissioned resources, and that's split into £3 million worth of mental health and approximately £5 million worth of learning disabilities. The majority of the support we offer is in-house, but for those people who are complex or have more complex situations, we often have to arrange spot provision which is outside of the borough. So quite a bit of our complex care is outside of the borough, and that's detailed in the report. The kind of the date of the review, which was 2024, we had 168 people in supported accommodation, but that very much varies. And you can see in terms of £8 million per year, that obviously there are people with a range of complexities, you know, costing kind of a significant amount of resource in those kind of in those facilities. In terms of what the report's done, we commissioned that in 2004, and you've got that in Appendix 2. So that goes into a lot of detail about what was looked at, the people that were spoken to, you know, all of the data that the strategy's been based on. So obviously, if you want more detail than I'm giving you or that's in the report, then Appendix 2 will kind of give you that in quite a bit of detail. But a number of the issues that came out of that were accessibility of accommodation. So in terms of people that have some difficulties around maybe they need a wheelchair or they may need a wheelchair, or kind of other accessibility issues around neurodiversity, we don't accommodate those people very well, and we don't meet their needs as well as we should be able to. We don't do very well with dual diagnosis, so we have people who tend to be split into, we put them in accommodation for mental health or for learning disabilities, and of course we know that people have a range of kind of requirements that often span different kind of groupings that we tend to kind of put people in. So again, it doesn't do well for people. our move on, we want obviously people to be able to become as independent as possible. Some people are able to move on into their own independent accommodation, others aren't, and that's fine. But we don't do very well at providing that kind of move on facility for people, and it's not particularly flexible. And our schemes as a whole really lack flexibility because, as I say, they have tended to develop in a bit of an ad hoc way, as opposed to developing in a way where we've got a very clear strategy and vision for supported accommodation. Just think about what else I can say in terms of means of background. Just in terms of moving forward, and again, it's very dependent in terms of demand because it does change on a day-by-day, week-by-week, year-by-year basis. But we're predicting there'll be an approximately 11% demand increase by 2040 based on the figures that we've looked at, and that equates to around 16 additional spaces per year. So we do really need to do some thinking if we're to manage that demand and actually meet needs of people appropriately. Some of that demand will come from the kind of the success of our special needs schools in Thurrock. Others can be around conditions or issues such as parents who become parents in older life and therefore are dying younger and then needing support for people who may, or their children who may have lived with them until a time where they are either no longer able to care for them or unfortunately kind of pass away. So there are a number of reasons for that demand in addition to population increase. So in terms of the strategy you've got in front of you, there are 10 clear objectives. I won't go into them because you've got them there. And the next steps, and they've come from obviously the work we've done in terms of the review and also significant engagement with providers, with people, organisations representing people that are requiring supported accommodation or who may need supported accommodation, and users of supported accommodation themselves as well. So we've done a range of meetings, one-to-ones, workshops, just to gather those kind of views. So this is very much a co-produced piece of work. In terms of next steps, we are now, Dawn, who can't be here tonight, but obviously is leading on this work, is pulling together a series of kind of steering groups with those people to look at different themes around how we deliver those priorities, what they actually mean if we're to be successful, and kind of what is the greatest priority or what has the greatest impact. So that's the kind of work that's happening next. Obviously, more than happy to come back and report on that as we're carrying on with that. And there are also already things that we're testing that we want to actually carry out further in terms of potential new builds, potential new ways of kind of supporting people on site with multi-agency teams, and also different types of floating support, which means more people might be able to live in their own properties with different kinds of support as opposed to maybe requiring supported accommodation. And equally, people who are in supported accommodation may be being able to have long-term tenancy or lifelong tenancies as opposed to having to move on. Because often that can be a disincentive if people are actually settled in their supported accommodation. I think I'm going to draw a line on it because I could probably talk for Britain. You've got obviously the report, you've got the appendices there. I'm able to furnish you with any more information that I can't give you tonight if you ask some things that I can't respond to. And the recommendation is obviously that you kind of note the report and endorse that. I've got the actual recommendation hopefully in front of me. Oh, yeah, recommended, obviously endorse the recommended findings of the review and support the strategy's 10 objectives. So over to you and any questions. Thank you very much.
Thank you, Kerry, for an excellent report. It's really good to see that you're doing it tailored approach, really, to the individual, and also to keep more in borough as well. I think it's fantastic. So I shall move to questions first, please. Okay, Councillor.
Yeah, so interesting that you say that the service at the moment for people with disabilities that need accessible spaces isn't particularly good. But if you're looking at new builds, would you be looking at lifetime homes which can be adapted as the situation changes?
Yeah, I mean, obviously we will be working very closely with our housing colleagues and also around development, because I think there are two things we could do potentially. One is the development of homes which are life, offer life and adapt with life, and actually provide support into those homes through kind of bit of floating support. The others are looking at potential new builds, which are then built along specifications which enable people to have kind of lifelong tenancies if they want to, but also mean that they can, if they are either have some accessibility issues or develop accessibility issues, that property is still, and that support is still okay for them in that scheme.
Thank you. Councillor Spade.
Thank you. I think this is a really great piece of diagnostic work. The report clearly identifies some very real problems and portrays them very graphically, which I think is really, really good. But by doing that, you've created a bit of a Schrodinger's puzzle, because I don't see really which way you're going to go to find answers that fit. And what I'm not really seeing in that report are sort of the prescriptive answers. You've got the diagnosis, now you've got to do it. And I'm worried about the lack of a timeline, because we're all under a timeline in Thurrock Council. And I'm also really worried about, historically we've been appalling at building houses of any description, whether they be, for special needs or whether they just be pure social housing. And I just don't know how you're going to rectify that because of finances and whatever. And I really would like to see some pressure put on by the people who've been commissioned, yourselves, to produce this report. Yeah, and clearly you're passionate. It's clearly a really good piece of work. And you look at there, you got a point, I think it's 7 and 9 are virtually the same thing, but it's summed up in 9, where it develop a new model of clustered supported housing spaces with individual self-contained properties and multidisciplinary support teams on site or in the local community. I mean, you just can't argue against that. It's exactly what we should be planning to do. It's a great piece of diagnostic work. Well, it's actually prescriptive as well. This is what we need to do. But I clutch at straws as to how we're going to go from this great master plan and turn it into. So again, I come back to we need to put pressure on as councillors. We need ideally you'll give us timelines and targets that we as a scrutiny committee can then go back to the housing department, to the adult social care department, and really do what we're supposed to do and scrutinise and say, how are you going to deliver on this? And I'll go back as well to the earlier part of tonight's meeting when we talked about working with developers and whatever. And I think we need to bring planning very much into this procedure, because we blithely talk. Section 106 agreements. I'm sick of hearing about 106 agreements because we're just not very good at doing them and whatever. But I think this is a real opportunity now to say to our colleagues in your colleagues in planning, look, come and get on board on this journey. We're going to do something innovative in Thurrock. We've got a great plan. We've isolated a problem. It works financially in the long term, which is great. I mean, whether it's a new unitary authority who reaps the benefit, I don't know. But I'd like to see the next stage of this, when you bring it, to be a little bit more focused with some real targets. Because I think only by setting dynamic targets, attainable targets, short-term targets, will we make progress.
No, I absolutely agree. I think, it's how do you eat an elephant, isn't it? I think this is, it's a vast, I mean, I think the problem is because the solution is so multifactorial. So I think, the new builds, absolutely want that, working very closely with housing colleagues and housing, regen colleagues to try and see whether there are bits of land and whatever, but understand, that's a longer term aim, isn't it? But something we really want to kind of push towards and actually should be kind of ambitious for, because I think having something like that built would be fantastic. There are other things, obviously, we can do which are short, medium, long term, which will be identified as part of this part of the next steps of what does it look like in terms of delivering that strategy? How do we meet that demand year on year? What are we going to do it? And there'll be lots of things. Planning will be absolutely involved on that steering group, because yeah, you're absolutely right. It's not just about what we can build. It's about attracting investment into Thurrock. Part of this is around having a market management strategy as well. So it's about actually saying to either existing providers or potential new providers, look, this is the demand, come to Thurrock, or this is our direction of travel, this is what we want, and actually trying to shape that market. But you're right, we need to kind of have a more detailed timeline or set of actions in terms of how we're going to deliver on that demand, what that demand looks like, and then what that looks like. So I'm more than happy, once we've got that, to commit to bringing that back so you can kind of scrutinise that and then hold us to account for the delivery. Oh yeah, no, absolutely, particularly other people. But yeah, so I'm more than happy to do that.
Thank you. And I understand you've got an action log as well. So that will be reviewing as you go along as well, won't it?
Yeah, absolutely. So part of the piece of work we are doing now and next is exactly linked to Councillor Spate's point. So we've got the objectives, strategies are great, but actually they're nothing without then the planning forward. So we will have various steering groups now setting up the actions that we require and what that looks like, and around things like resources and long-term, medium, and what we need to do with various kind of whether it's the market, whether it's new builds, whether it's different types of provision. So that's what we're doing right now, and there'll be a range of people and stakeholders involved in that. So as Councillor Spade said, planning, housing, existing providers, new providers potentially. So yes, that's what we're doing next.
Do you have a timescale for the first sort of review and report?
I probably should know this. I may have to get back to confirm, because there is a date set. It's happening now. Obviously, some of this will be ongoing because some of it is going to be in so many stages, like the new build. But I think in terms of defining the objectives, what success looks like, and then definitely the short term, I would hope that would be in place by kind of December time. But I will come back and confirm that, just in case I'm not telling you something that's quite accurate.
Thank you. And I think Councillor Hooper, did you want to come in, please?
Yeah, I'm glad for your words, Councillor Spate, because I do think it needs monitoring. There is a commitment, though. This was actually a report written jointly with housing to identify what those housing needs were going to be. And you are right, we need to make sure we plan it and monitor it. And it's certainly something I'm very keen to do, because I think it's important we deliver this. I think the report is great because the report gives us some real guidance on what we need to do. And there are great opportunities in Thurrock. Thurrock, I think, is a place that can have great opportunities. We will have lots of new developments coming in, and one of the things that I'm particularly keen to do, and I've started work on already, which we haven't really spoken very much about, was about how planning and health and social housing work together to deliver what's needed in Thurrock. And those meetings will be starting in September. So one of the things we'll be monitoring in this is the actions from this report. And also the government have announced, or will be announcing, well, waiting to hear actually, what money we may get from the government around social housing. As they announced in the budget, billions of pounds have been allocated to social housing. We could be using some of that money to actually help us develop these plans. So it is very, very much on the agenda. And we're already looking at land we can potentially use to start building some of these developments.
Thank you. Councillor Leakey.
Thank you, Chair. Thank you for the report, Scary. I was going to ask about shared lives, because I understand people with disability and mental health issues can actually, get shared lives support. So have we looked at shared lives support in terms of, placing people with, adult foster carers that can actually, provide them with that support? Thank you.
Yes, we do. We have a shared lives scheme in Thurrock. We've had it in place for a number of years. It's recently been retendered, and there's a new provider working on that, because we've got some successful shared lives places, but they are fairly small in number. So one of the targets, obviously, of the new provider is to grow that, because it's a great scheme, and it will kind of provide placements for whoever is suitable for that kind of arrangement, whether it's learning disabilities, mental health, neurodiversity, a range of issues and requirements. So I can get you more detail. I haven't got it with me tonight. I can get you more detail on shared lives if you're interested in that and the detail. But yes, we have.
And in terms of ICB, because you can actually work with ICB, some cases can actually be managed by ICB, in terms of supported living accommodation. They can actually support with some people with disabilities that can actually be funded by ICB. Is that something that you can explore?
You'll have to ICB in terms of
people with disabilities that can, ICB can actually fund some accommodation for them to stay there, to have that support. Is that something that you can explore?
Yeah, I mean, absolutely. I mean, in terms of placements, obviously we will manage placements with people that have an adult social care need. In terms of people that have health needs, and also other local authorities can contract and place with those providers. They don't just have placements from us. They have placements from a range of other commissioning authorities.
Thank you. Councillor Johnson.
Thank you, Chair. Councillor Aliki stole my thunder. I was going to speak about shared lives, because I do believe we still have that, and it is an accommodation service as far as I'm aware. So I was really going to ask that within this strategy, maybe we could offer some kind of incentives even, or more support, because I think overall that would probably save the council money rather than costing it money. But I do think it'd be great if we could bring that into a report to say if there are some incentives, or at least extra support that we can give through shared lives, because I think it's been going for a while now and it works.
Yeah, and again, apologies, I haven't got the detail here tonight, but I know that one of the purposes of having the new provider was to try and accelerate the number of placements and to look at how we best did that. So I think, incentives, how we recruit people into that. We've even looked at people who have maybe provided care for a child or for an adult who's moved on and still want to provide some care. Maybe we can recruit different types of people who we haven't actually been able to target at the moment. So yeah, we're actively looking at all of that. But again, I'm quite happy, again, if this is of interest, to bring something back on shared lives, or to provide a briefing on shared lives if that's of interest, because I'm conscious that I haven't got the detail that you might want.
Thank you. Would anyone else like to ask a question or make a comment or anything at all from the committee? Yeah. Councillor Johnson.
Sorry, I think it's along the same lines. It's definitely about supported living or supported accommodation. I've had several residents moan about living in accommodation for, say, over 55s, where they're still of working age, which I think is still supported living or accommodation, but they're having to pay for things like Careline when they don't need it. They're working people, they don't need Careline. I'm just wondering if we can maybe look into that, because although they're paying for it, it must be costing the council something to supply that Careline.
I think the properties will be sheltered housing, which will fall under housing. So, but I think, and again, I'm going to say this again, aren't I? I haven't got the information. But actually, in terms of how that works, I think when you obviously want to go into sheltered housing, I think you are actually signing up for that, because actually one of the benefits of having something like sheltered housing, sheltered accommodation, is the additional support you have with it. You might not need it there and then, but actually, because they are homes for older people, then there is a likelihood that you might need that care line at some point. And it's the same same with our extra care housing. You pay, part of that is around paying for an element of care that you might actually not even need, but actually you choose to go into extra care housing because actually you know that at some point you might require that. So it's a service that goes with that kind of facility. So that's why the charge is there, and that's what. But again, you know, if you're hearing a number of issues and it's creating issues, I'm quite happy to report that back and get a response. So.
Thank you very much. And I know you're working at the moment along with Gina and her colleagues on the autism and neurodiversity strategy, and I would think that that's going to link in quite closely with this report as well, isn't it? Because so that would be, yeah.
Yeah, just I suppose I should have said this is one of a number of commissioning strategies, and again we can bring them here as and if appropriate, but working with Gina and Thurrock Coalition very, very closely, because all of the strategies that we're developing are co-produced. Gina's very much a part of that, and we know that actually there will be interdependencies between those strategies. So the findings, for example, of our autism and neurodivergence strategy, there will be some things that actually span here and some of our other strategies. So we need to make sure that we make those links and that actually, yeah, we do make sure that supported accommodation for people with autism and neurodivergence who might need that is appropriate to their requirements. So, yeah.
Thank you. So I think we'll read out the recommendation in this. Oh, sorry, Councillor Spake.
Thank you, Chair. I was going to hopefully speak before we got to the recommendation. I think it, as I say, I'm very impressed with what's been put before us tonight, but past precedent, you know, I've sat and looked at some great plans in Thurrock in the past and they never materialised. I think I would like, with your indulgence and other members, that we set some sort of timeline or accountability in terms of where it says, you know, recognise the key findings of the review and support the 10 key objectives outlined in the new strategy. Well, of course, we're going to do that. But in terms of what I think we should also say is, and, you know, ask for, you know, a period of, whether it's a period of time, let's say, you know, that this be done within the next year or the next 6 months or whatever people feel, and that a report be brought back to this committee at an appropriate time, and I would take Kerry's advice on that one, because, you know, far more fluent or even Mark. But I do think our job as scrutiny is to set targets that people have got to, otherwise my fear is it'll just disappear, you know. I mean, and it's all about, to me, and I'm going to be brutal, it's about us keeping, as overview and scrutiny committees, keeping pressure on the senior leadership team in the council so they don't dissipate and not bring these things back. So whether Claire or anybody would come up with some other words, but I really would like to see that in there.
Thank you. I mean, we have, as Kerry said earlier, there is an action log, and we have got a first date for that, which you were going to check, weren't you, for around December. So there are timelines in place, but I don't know. I don't think it's probably not appropriate to fix them fixed targets at this point. Is there maybe just an update, unless you want to come back?
Yeah, just to say, I think some actions will be easier than others. So some of it will be around an action and a timeline around potentially developing approach or testing an approach, which may then lead to more concrete action. So as long as the understanding is that there would be, yeah, there needs to be some flexibility on how things, because some of these strategies are going to be developed over a number of years, then we can bring, yeah, in the update, we'll try and actually set that out for you.
I mean, what we could do to get round it is which we've done in the past, is ask for a timed briefing note, which is a sort of a stopwatch on the job. So say, you know, could you bring us a briefing back? It doesn't have to be an agenda item at this minute, but it can be a briefing note for committee members. So there is an obligation to put pen on paper about something.
What I would suggest then is, if we've got an action log and you're reporting back, you think approximately December, in February you're reporting on the autism and neurodivergent strategy, maybe we could include an update at that point. Yeah. Okay. if I read out the recommendation, so it's to recognise the key findings of the review and support the 10 key objectives outlined in the new strategy, and to report to ONS on the update in February. Okay. Thank you very much, Kerry. Thank you. Okay. If you can stay, Kerry, or if you'd like to leave, then that's fine. Thank you. Yes, thank you. So item 8, we're going to discuss the work programme, which is on pages 127 to 130, and may I ask Claire to present this item, please.
Thank you very much, Chair. Since the publication of the agenda, there's been an amendment to the work programme document. The Autism and Neurodiversity Strategy has been moved to the February meeting, with the Adults and Health Directorate Strategy filling the January slot. So it's just a swap of the two agenda items. It is also proposed that the financial outturn reports for Q4 for 2024 and 25 and Q1 will be presented at the October meeting, which is subject to the committee's agreement. Is this something that the committee would like to see at the October meeting? Yes. Perfect. I will add that to the work programme. Finance colleagues are aware as well, so it's not news to them. And we're also looking to have a report from the Health and Wellbeing Board Chair, Councillor Hooper, in January 2026 to allow the committee to scrutinise the work of the board. The report may highlight future items for scrutiny to review in more detail in the following municipal year. And actually it would link quite nicely with the alignment of the health and wellbeing strategy and the Better Care Together integrated care strategy. So we are looking to add that as well. Chair, I'll hand back over to you.
Thank you, Claire. The other thing we wanted to talk about was the maternity CQC inspection. We are going to request a briefing note. I think an email did go around circulating to say if members had anything particular that they wanted to ask on that. And if you do have anything, if you can email Claire for that, please. Okay, Councillor Spate.
Yeah, thank you, Chair. As I alluded to earlier, I'm extremely concerned about the potential loss of Thurrock Health Watch. I think it is, and it is a very real potential loss. I've sat down with Kim and members of her team, and you know there is a great deal of concern from them about what their future is, because the funding has been cut. There are funding streams that are going to filter down, from what I can gather and what they can gather, and it is a bit vague, are going to come through the council, and quite whether they would then be allocated to support something as structured as Health Watch, Thurrock Health Watch, or not, I just don't know. But I believe it's our job to try and protect services in this council and ask Cabinet. I mean, that's the idea of scrutiny. We take things to Cabinet, and I don't know whether we empower Mark or somebody to raise the issue at Cabinet, or whether we put it on our work programme as an issue so it's there and we ask whoever it may be, whether it be Kim or whether it be somebody from within the council, for us to discuss it, because I think if we don't discuss it, I'm not sure Cabinet will discuss it, and if it doesn't get discussed at all, it'll be gone before you know it. And I think for Thurrock to lose Health Watch would be a real shame, and I think I champion what they do. They don't get everything right all the time, of course they don't, but they do make a massive difference.
Yes, I agree, Councillor Spate. Kim did come to our informal meeting and gave us a summary of what's going on. She is coming, presenting a report at the next meeting, but we can definitely add something on to the work programme to see what we can do with regards to how the council can help with that. Yeah, thank you. Councillor Hooper.
I actually echo your concerns, Councillor Spate, but the government are, I think Thurrock Health Watch, as don't mind saying this publicly, I think is the exception to the rule. I think health watches in other places, I don't think has worked as well as the Thurrock one. I know you said they don't get everything right, but they do an awful lot of things right. And I think it'll be a major miss for our community not to have Health Watch, who would monitor health services and how local services and social care are delivered, and give advice and support on positive advice and support on way forwards. One of the challenges will be there will be changes in legislation from central government. So I'm very keen to keep something like Health Watch, so it may not be called Health Watch, is what I'm trying to say. I've shared this with cabinet members, and I've shared it with Kim, and I'll be wanting to work with you as a committee to look if we can find a way forward in the future.
Thank you. Are there any other comments or questions about the work programme at all, please? Okay, thank you. So item 9 is the action log, and also we've got item 10 as the recommendations tracker. So if Claire, you're able to present those 2 items, please. Thank you.
Thank you, Chair. So currently the action log and recommendations tracker does not have any open actions, as this is the first meeting. So following this, I will update it, and in preparation for the October meeting, the committee will be provided with the responses that have been requested from colleagues today, and will be published again as part of your paper pack ahead of the October meeting.
Thank you. So unless there's any other queries or areas of business, I'd like to thank everyone for coming this evening, and that concludes the business of the meeting this evening, and I declare the meeting closed at 9:05 p.m.